welcome back to Roials Capital, the show. Today we're profiling a leader who's fundamentally shifting on how healthcare organizations find value, and I mean alpha in private equity. And if you have ever wondered where the real margin is hidden in big deals, in multi-billion-dollar systems, our guest today, Joyce Nwatuobi, has built a career finding those exact answers. So I would love to hear, please tell me a little bit about you, yourself also. It will be very interesting to hear more about you.
Thank you, Jonas. Thank you for having me. Happy to be here. I'll say upfront, I'm not going to talk about healthcare in the traditional way. I have lived in healthcare. I've done healthcare in different capacities, in finance, in operations, in strategy. And the numbers matter, but the story behind the numbers is where I live. So it's understanding the story behind the story behind the numbers, and truly being able to capture that and create value for the organizations that I work with. And so that's really me in a nutshell. Finance leader, operations leader, strategic leader. I've worked in organizations where I built 17 joint ventures with physician partners, where I was responsible for $4 billion construction finance project, a multi-site, multi-year and multi-billion-dollar project, and have also been involved in over $450,000 acquisitions within healthcare, as well as many other things, including operational debt and reducing operational debt within deals, and truly helping not just acquiring, but the integration and finding that value between those two. So that middle point where you acquire, and then you have someone who can truly unlock the value of that acquisition. So that's been exciting. I've done that for about 20 years, and I'm happy to be here.
Yeah, you told me before that you started with 3 acquisitions at the beginnings, and it happened to be healthcare, if I understand it correctly. And that's kind of how you came into the industry. Do you want to tell the audience a little bit about that?
Yeah, sure. Yeah, so my first experience with healthcare acquisitions was several years ago. I was a finance manager, and we had acquired a number of clinics in New England, in the New Hampshire area, and we didn't really know what we were getting ourselves into. And so one of my jobs was not only understanding the numbers, but also understanding the drivers behind the numbers operationally. And as a brand new finance manager within healthcare, it was different. It was not the typical just look at the P&L, look at the KPIs, make sense of it. There was also a lot of cultural things that had gone on with that entity. There were union arrangements, physicians who had long-term relationships with the community. So it was all of those, understanding the human factor, and then translating that into what would happen if we were to lose one of the key players, or one of the nurses, or one of the physicians, and helping the leader over that market map it out. So it wasn't just a financial analysis. And for me, it was really interesting because I'd never done anything like that in finance. It was because M&A is unique in a sense, but healthcare M&A is just totally different, because you have to factor in the emotional intelligence, the human factor, because we're dealing with people's lives, right? So it's not a gadget, it's a person. And so really understanding that, and so I learned that early on, and that really helped me in my career in healthcare and in M&A.
That's great. I just interviewed a beginning M&A roll-up entrepreneur. I got a text from him that he completed his 3rd acquisition just recently, and he sent a picture of them being very happy. And I think it was just the right age for them, because they want to retire. Right. And he was on his 3rd acquisition. and they look very happy. And I was just, that was just why I was curious about the beginnings, because I could easily relate.
Yeah, it's fun. It's a lot of fun, especially when you get it right. It's not fun when you don't, but it's fun when you get it right.
Yeah, I have a mentor that actually in the USA that done one acquisition also that was not as good, but yeah, he did a lot of deals that has been very good later on. But I think we learn from those deals. I think it's foundational. And I think what's very interesting also to hear more about is, you talked about unlocking the hidden alpha in these healthcare buyouts, and actually growing them and everything. And I think about the post-acquisition that you mentioned also. And you wrote a very powerful post about challenging assumptions in legacy contracts, and you saved a whole lot of money there.
Yes.
And for funds or PE funds or other type of acquirers, those who want to buy this type of companies and execute this type of roll-up, or if it's a buy and build strategy and add-ons in healthcare, where are the biggest hidden operational inefficiencies that you see, but let's say a financial analyst, they might miss it?
Yeah, so that's a great question, Jonas, and I'll just expand on that example. So, and I'll give a little bit of a background. I've seen this happen in many different capacities, whether it's the electronic health record, or it's your telecoms contract, or it's your Microsoft Office contract. Everywhere, I feel like I see it without trying to see it. It's just the way my mind works. And so, specific to this example, one of the things I've noticed is people stop asking questions after the first question. So you ask a question and they give you an answer and it sounds logical and you stop. Like, yeah, it makes sense.
Yeah.
That's where I ask the second question and the third and the fourth. And so in this instance, I was reviewing a legacy electronic health record contract. This contract was written 4 years prior, and they had migrated to Epic, and everyone was migrating to Epic. And so as part of that, you have the legacy software where all of your records were kept. And in America, and I'm sure in Europe as well, you have to maintain records for a period of time, especially if it's patient billing information or patient health records, and it could be up to 10 years. And so as part of the migration, the company had said, we need to pay this existing legacy contract for another 10 years. And it was baked into all of the assumptions, and everyone just said, sure, no problem. And they moved on to the new platform. They moved on to the implementation, the adoption, the optimization, all of those things, and totally forgot about the old contract. So what happens 4 years after? I showed up and I said, show me the contract. Show me why we're paying this $10,000 a month for software we're not using for the next 7 years. And no one could answer that question. I said, okay, that's fine. Oh, we need to do this, we need to do that. I said, that's okay. Let's find out what the assumptions were based on. What was the contract based on? The contract was based on 50 people. The organization had 10 people left. The remaining 40 had left between that time frame. So they were paying for something no one was using. They were paying for something people only use once or twice a year. And the assumption was it would be used all the time. And they were paying for something that they just assumed they had to keep paying. Yeah. Right? That was the assumption. And we have to do this because healthcare regulatory laws say we have to. And so, yes, we do. And I try not to say but and so what? And so after asking those questions and really looking at the reality, going back to the vendor and telling the vendor, hey, we only have 10 people, and these 10 people only access it 3 or 4 times a year, if that. And here is what we want. We want you to reduce your price, otherwise we're going to go somewhere else.
Yeah.
And at that point, they knew they weren't doing much. They knew they knew the numbers. They knew it was just slush money for them. And so they accepted it. And it was 20% of what we're paying. So instead of $10,000 a month, it went down to $2,000 a month. Nothing changed operationally. No one felt it. No one complained. It just happened. We just signed a new contract for another 7 years. End of story. But
it makes me think of the state-owned. I mean the public. They're paying for the same.
I know. You just assume, well, we have to do it. Well, you don't. You have to ask the question. Yeah. And so for me, it's
where the tax money goes. Don't do that.
Right. So the financial analysts saw the numbers, probably asked for the contract, didn't ask any follow-up question. So it wasn't as though people didn't see that there could have been opportunity. It was more, it became operational debt that's just compounded over years, and it was part of the fabric, part of the baseline, and no one challenged it. And so it's one thing to see the data and the number. It's another thing to move from that to, so now what? And using that to say, how do we unlock that value and truly capture what we're using versus what we assume we're using. So it's a disconnect between the assumptions and reality, and bringing that together.
Yeah, love it. That's very good. And then you're finding alpha directly from nowhere. I mean, from somewhere, but directly, and it's very good compared to the multiple that was paid, right? Because you're making, and it's good if they hold shares, they're gonna be more profitable, and if it's an exit later or a partial exit, I guess it's gonna be very beneficial to have been acquired by your firm then, because
right.
they will have maybe a second exit or maybe keep some shares or whatever.
Right. And Jonas, to that point, imagine a PE firm that's working or an organization that has access to multiple of those. So you acquire a healthcare organization and they have multiple contracts like that. And the assumption is the contracts are the contracts. In some cases, some organizations don't keep a record of all their contracts. And so starting with the foundation, like what were the contracts, what are the assumptions of the contract, and then building from there. But that was just one example, right? We didn't want one organization. Imagine this multiplied by 10. So that's 576 times 10. That's $5.7 million multiplied by 10 companies. So it's one contract times 10, and then times 10 organizations. So there's a lot of opportunity here if people.
Also, I think as a seller, what they might not think about directly is that if they are acquired by private equity and you have this kind of negotiations going on all the time with software and other type of vendors, they are actually gonna have lower price probably,
right?
Because it's this huge opportunity to negotiate prices for their. And also another thing I looked into in your profile was that you manage over 3 billion in capital projects. How should mid-market private equity funds optimize their capital planning when scaling highly regulated health systems or outpatients groups? Because I don't know exactly how it is in the USA, but here in Sweden, it's very regulated.
Yes.
How do you go about doing that?
So another great question, Jonas. And one of the things I would like to start with is healthcare is a highly regulated environment wherever you go. So whether it's Sweden, US, UK, everywhere. And in the US, it's I think there's a little bit more flexibility because all of the states have different rules. So depending on the state, you could have what they call certificate of need. And that means you have to prove there's a need for your healthcare services before you expand or before you build additional clinics or expand your hospital and things like that in some states. Some other states, they don't have that. So it could just be, well, I just want to build 5 dental clinics and do that if you have the money. So that being said, to sequence your capital in healthcare in general, especially if you want to grow in a meaningful and intentional way, you first need to understand the regulatory landscape. And again, that's across every geography. So understand the regulatory landscape. What are the requirements by states? Speaking about the US, what states require certificate of need? How long would it take? In some cases, it could take up to 6 months, could take 9 months. I've been in a recent situation with the Home Health Agency. The certification for CMS took about 6 months, and the owners thought it would take like a month, and it just took up all the time. So understanding that before you deploy capital is really, really important. That's, in my opinion, that's one of the biggest first steps. You also need to understand, it's dependent on the facility, you may also need to ensure the licensing, you need to send letters to the community, wait for them to respond, call for a town hall meeting. All of those things take time. So it's fine to have the money, but it's also important to understand the time it takes to go through some of these hurdles, so you don't deploy cash or capital and you have your capital tied up in regulatory stuff. Some of the other things that I've noticed, and in my $3 billion example, we have, and when I call it $3 billion because the hospital itself was $3 billion, but the entire project was 4.6 because it was a multi-year, multi-campus project. So as part of it, we had to build a hospital, build a medical office building, and also build a plant, an energy plant. So the full contract, the full project was $4.6 billion. So diving back in, I wanted to talk a little bit about the project. So the multi-year, multi-billion-dollar project and multi-campus, and it was hospital, energy plant, medical office buildings. It was a really comprehensive build. And so the challenges extended well beyond construction. It wasn't just about building a space. It was, supply chain was crucial. We had to make sure we were able to plan for that. And some things we had to purchase 3 years in advance because we wanted to lock in the prices. And some of that was like a 20% change in pricing because of inflation. And so knowing what we needed to purchase, like steel, we need to have steel for the buildings. And so buying steel upfront and locking in the prices was crucial. We had things like labor. We needed people to build the facilities, and many of our laborers were unionized. And so understanding that, and also looking at people who had the institutional knowledge of the project, people who had been with the project from the start, and realizing if we were to lose them, it would set us back. And so one of the things that I proposed was paying them a retention bonus to lock them in for the rest of the project and just make sure we had those key people, like 3 or 4 of them, till the end of the project. It wasn't a lot of money, but it was just the thought behind making sure we didn't lose the knowledge. And then the last thing was tied to the overall operational changes. So you start a project, you plan it, and then over the next 5-10 years, things change, and being able to plan for those things and making sure that you're not building something for the past, you're building something for the future. And so as part of planning and being very precise with your planning, but also being very agile in how you execute your plan. And truly, because $3 billion project is not the same as a $3 million project. So you have to be really thoughtful about how you do it and how you truly plan for a facility of the future or for a project of the future, whatever it is, right? Plan for the future, knowing that you're investing a lot of money into it.
It sounds like you're going from being a CFO to having this principal alignment, this principal mindset, and really looking long term, not just a career staying there 5 years, but really long term planning. I want to ask you, what makes a healthcare CFO truly dangerous in a good way, or like a buy side mandate?
Yeah. So when I heard you say dangerous, I'm like, I'll never call myself dangerous, but I could be. So I'll say the most valuable CFO, the dangerous CFO, like you say, is not the typical CFO, not the typical accountant, not someone who's just interested in closing the books or making sure the books balance. It's someone who's willing to see the numbers and translate the numbers and say, the numbers say this, but what does this really mean? And again, it's not reporting. So that's also a factor of what CFOs do, but it's intelligence in a word. So it's actually unlocking intelligence. It's a CFO who can see beyond what the numbers tell them. And so I'll say in my experience, it's understanding in healthcare as well. It's understanding who truly has the power. So I've worked in clinic space, hospital space, health systems, healthcare, different capacities. And I can tell you, the person with the power is not the CEO.
Yeah, maybe there's some unknown persons that,
It's usually not the CEO. It's not the COO. It's not the people with the C titles. Sometimes it's the nurse. It's that nurse who has access to, who knows all the patients by name, who the doctor relies on, who the doctor can call at 5 a.m. in the morning and tell them, I need this done, and it's done, who the team members trust, who can literally walk out of a clinic and carry the entire team with them because they've built that kind of trust with their team.
all the patients.
And all the patients too, right? So, and I've seen that happen in my years in the joint venture world, where you have people who, it's the nurse, she's the most powerful. In some cases, it's the physician, it's the doctor he's been in the community for years. He's like the mayor of the community, even though that's not his title, but everyone knows him, everybody respects him. And so being that CEO who understands the informal influence networks and truly taps into it, the CFO who walks the room, walks the clinics. A lot of CFOs like to be in their offices behind a computer, looking really important and feeling like the numbers are everything. But in my experience with the project we just talked about, I was on site twice for like hours, just walking the entire campus while it was being built. And they were showing me, here is what the contract is, the $200 million contract you signed last week. Here is what that went into, and I could tie the numbers back to the actual reality on the ground. The other thing I would like to talk about really quickly is healthcare is a people business. It's not widgets. It's not fast goods. It's a people business. And so understanding that people are crucial in how the numbers show up, and a CFO that understands that will go a long way in unlocking value, because there's some things you see in the break room, there's some things you see, conversations you hear that you wouldn't see in a data room, you wouldn't see in a slide deck. But if you embed yourself into how things run or understand how operations run, you become that CFO that people can talk to and truly help them translate numbers into reality.
Be relatable and
Yes.
maybe even like go to the sports club they're part of, or like going to the local church or similar in small towns when acquiring a company. I don't know.
Yeah, I don't know if and maybe and I'll say in my experience I've done the not traditional things that finance people do. So I've gone golfing with people. I've gone for baseball games, right? There are things that happen outside the boardroom, outside the meeting rooms, where if you're not part of those conversations, you're just not a part of it, and you can't force people to be themselves in an environment where it's formal, so it's finding that that sweet spot of professionalism, being professional but also being relatable, and truly having emotional intelligence. Someone told me, and I respect him a lot, he said results move at the speed of relationships. So I would say in this instance, value moves at the speed of relationships. If you can unlock value, but you need to have, especially in healthcare, you need to have the relationships to unlock the value as well. So there's financial intelligence, operational intelligence, and in my opinion, a third one that helps to compound it all will be the emotional intelligence as well.
Wow. Yeah, that's very, very interesting and even fascinating and compelling. So how do you make like a thesis out of all of this? Is it possible even? It's about relationships, it's about flesh and blood. It's real relationships, real humans, and it's hard to theorize that, right? It's very
it is and it isn't, and I'll say in a way that for someone who's lived in this world, I took it for granted because it came natural to me, but it's teachable. Okay. And it's teachable in a way that
let's say I am INTP. I'm a very logical person.
Yeah.
I love to see numbers and find different connections and make a thesis out of things. Like I'm an academic, but I'm not. But that's how I think. Like very structural, like an engineer kind of.
Okay, so I'll try for someone like you, right? Yeah. So I'll say financial intelligence helps you understand the numbers. Operational intelligence helps you understand why the numbers are the way they are. So the drivers of the numbers, how the numbers came about operationally. The emotional intelligence, you could call it culture, you could call it the soft piece of it, is it helps you see what's coming. So in financial, hard, black and white numbers. Operational, why are the numbers the way they are? Unlocking the numbers, walking the facility, seeing things, and truly understanding why things are the way they are based on what you see operationally. But then understanding why the nurse manager is crucial and doing something about it. Understanding how in one particular instance, 25 surgeons were driving the entire margin of a $2 billion health system and no one knew it. Understanding how if you lose one of those surgeons, you've lost a significant margin, and doing something about it, making sure people knew who they are, making sure when they asked for supplies, they got their supplies, they had their staffing, they had the operating room, all of those things. It's the emotional intelligence of understanding the fact, but also moving to a point where you're doing something about it. And it's building those relationships and helping people. It's like forecasting and seeing ahead. So
I love it. And I think we need people like you to really understand it. All types of people are very much needed, and this is like another level for me to I think it would take a lifetime for me to really get into that. I think that you are. I'm very happy for this conversation that we had. Thank you very much for your time, Joyce, and I really appreciate you sharing what makes your heart sing, and really having another perspective on healthcare acquisitions and the private equity industry.